Welcome listeners and viewers to this webinar, which will describe ICP, that's intrahepatic cholestasis of pregnancy, and the impacts it has on patients and their unborn children. With me today are two world-leading experts, Dr. Katherine Kohari from Yale, Connecticut, United States, and Katherine Williamson from King's College, London, both of which are esteemed world leaders in the ICP. My name is Ed Tucker. I'm the Chief Medical Officer for Mirum Pharmaceuticals, who is evaluating and conducting clinical research into ICP. First, before we get into the discussion on ICP, I'd like to introduce my two experts on the call today. Katherine Kohari, would you like to introduce yourself to this webinar?
Yeah, so I'm Katherine Kohari. I'm an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at Yale School of Medicine in New Haven, Connecticut. And I've been interested in cholestasis research since my early days as a resident physician in OBGYN.
Great, thanks very much. And Professor Williamson, welcome to the call.
Thank you. My name is Katherine Williamson. I'm Professor of Women's Health at King's College, London. I trained in general internal medicine and endocrinology and then specialised in diseases of pregnancy, obstetric medicine. So I now also work as a consultant obstetric physician at both St Thomas's Hospital and King's College Hospital.
Great. I think we've got two excellent experts for our discussion on ICP on this webinar today. And we hope that really enables our viewers and listeners to understand that they're going to be informed and educated by ICP today. Professor Williamson, could you just describe the disease of ICP? What is actually happening in patients from a biological perspective?
ICP is the commonest pregnancy-associated liver disorder. Cholestasis itself describes reduced bile flow, which can be caused by a number of things, including obstruction, for example, from a gallstone. But in ICP, it's typically due to abnormal bile flow at the level of the cells of the liver. And this is likely to be explained by the influence of the high pregnancy hormones, reducing bile flow, particularly in women who are more genetically predisposed to developing cholestasis.
Great. And Dr. Kohari, tell me a little bit about those predispositions. Who is predisposed to this disease or this syndrome of ICP?
Well, as Kath mentioned, there are some women who carry genetic alterations in some of the genes that are responsible for creating the proteins that help transport those bile acids. So that's one group of patients. Certainly, family history can be a risk factor. Underlying liver conditions is another risk factor for cholestasis of pregnancy. And we think things like multiple pregnancies, and of course, having a history of cholestasis in a prior pregnancy is one of the most common risk factors for cholestasis in a current pregnancy.
Oh, can I pick up on that? So you're saying that if you've had ICP in past pregnancies, there's a chance that you'll have another episode of ICP in a subsequent pregnancy. Is that correct?
That is correct. As with all things in medicine, if something happened to you once, you're usually at increased risk for it happening again. And with cholestasis, it seems to be that women are at an increased risk for recurrence. The exact rate of recurrence is somewhat hard to know. It's been anywhere in a range from a 50% to 70% chance of it recurring again. But certainly it's something for all women to mention to their doctors in their current pregnancy.
That's great. Dr. Kohari, could you elaborate on the role of serum bile acids in intrahepatic cholestasis of pregnancy, please?
So bile acids is a substance created by the liver that helps to process the food that you eat for excretion into your intestines. And when it comes to cholestasis of pregnancy, we know that women have elevated bile acids. And there's a lot of research being done, especially by Professor Williamson and others, looking at what exactly is a normal amount of bile acids in pregnancy and what are elevated levels of bile acids in pregnancy. And it's actually somewhat unclear, even up to this point, what the abnormal value of bile acids should be to make the diagnosis of cholestasis of pregnancy. how we should even draw that specimen or test for that lab, and then how to follow throughout the course of a pregnancy with bile acids, as those levels tend to fluctuate over the course of a day, before and after eating as well.
Professor Williamson, as we heard from Dr. Kohari, you're an expert in bile acids in ICP. Could you tell us a little bit about your research and how serum bile acids or bile acids in general affects the patient, and what really you'll be looking for in a patient with elevated serum bile acids?
Yes. When we think about the patient in ICP, it's important to think about the mother and maternal disease and the pregnancy and complications of pregnancy. Bile acids are particularly important in ICP when we consider the potential adverse outcomes that can occur with the pregnancy. And we and a number of other groups internationally have been trying to study the influence of bile acids on pregnancy outcome. And I have to say a big thank you to Katherine and our many other collaborators, because this has been an international effort. The first work to try to understand what biochemical changes were of importance in a national cohort study was done by the Swedes, by Anna Glantz with Hansel-Rick Marshall and their team. And they studied women with itch in pregnancy and showed that the poor pregnancy outcomes didn't occur until the bile acids in the mother's blood went above 40. We then did a follow-up study in the UK, only studying women with bile acids over 40, and followed on from the Swedish work that showed that spontaneous preterm birth and some other markers of fetal distress were higher. Because we had higher numbers, we were able to show that stillbirth also occurred more commonly. But we were very keen to try to understand whether there were different thresholds for different adverse outcomes of pregnancy. And so with all of our wonderful international collaborators sharing their data from many, many studies, we were able to evaluate thresholds. And it appears that for two of the very important adverse outcomes, spontaneous preterm birth and stillbirth, there are thresholds above which the bad outcome occurs. For preterm birth, spontaneous preterm birth in particular, this seems to be 40 micromoles per litre, whilst for stillbirth, it is 100. So this was a piece of work that we published a couple of years ago. We've also done some work to try to understand which bile acids may be of relevance. And it appears it's the primary bile acids made by the liver that are the main ones that go up in ICP. And these are more harmful bile acids, and these seem to have a number of effects, including maybe affecting the way the baby's heart beats and the ECG trace of the baby. So we and others are now doing more work to try to understand how bile acids themselves may cause the outcomes. And of course, we all want to find a way to prevent them going up or bring them down, because we hope that will also prevent the bad outcomes.
So you mentioned a couple of values of serum bile acids. What's a normal value for a serum bile acid?
This is a very good question. And as Katherine said, our people are still trying to establish this. It's important to think about normal bile acids when women are fasting and when they've eaten a meal. This is true outside pregnancy as well as within pregnancy. Fasting bile acids tend to be relatively low, and after a meal, they rise. In pregnancy, we recently published a study where we showed that typically they go to 20 or above after eating a meal. And given that peak bile acids are what is associated with the poor outcomes in pregnancy, for pregnancy management, this suggests that it is sensible to study bile acid concentrations, not when a woman is fasting.
Professor Williamson, any guidance from a physician standpoint on how to manage these patients with regards to their elevated serum bile acids?
Yes, there are a number of guidelines, and many of them are currently being updated because there have been several papers that are likely to be changing clinical management. In the UK, the Royal College of Obstetricians and Gynecologists guideline is being updated as we speak. It has just been sent for peer review, and I suspect expect within 2 or 3 months it will be published and will reflect the recent work, such as the work on bile acid thresholds. There are also European guidelines, again being updated this year, and there are now new American guidelines, which Dr. Kohari may want to speak more to.
Dr. Kohari, that's a nice tee up from Professor Williamson there. Tell us about the new guidance.
We do manage cholestasis of pregnancy in the United States slightly differently than they do in the UK, which is to say patients tend to be offered earlier delivery in what we call the late preterm period, which is 36 weeks of gestation with cholestasis of pregnancy. But taking into account the newer data, it's now permissible and makes sense to not expose these babies to preterm birth and allow women who have bile acids who are slightly lower to go further into their pregnancy and actually can be delivered 37 weeks and upwards of to 39 weeks, depending on their bile acid level. So the new guidelines from SMFM, or the Society of Maternal Fetal Medicine, it actually has a much more nuanced approach, and allowing us to tailor patient care based on what's going on with the physiology of the disease in each individual patient to protect both the mom and the baby.
Just picking up on what you mentioned there, Dr. Kohari, the training I had many years ago was that if an unborn child was able to deliver beyond 35 weeks, that was a mature baby at birth. I think what you're describing is perhaps that we want to extend as far as possible the gestation period. Could you maybe elaborate on what are the advantages of extending gestation to a normal term of 39, 40 weeks?
Well, it's come to light in the last 10, 15 years that at the end of pregnancy, there's actually some really important, what I call fine tuning of the baby, especially in the respiratory system or the lungs. And that babies who are born under 37 weeks do have an increased risk of respiratory issues. Nothing major in the life-threatening sense, but in the perspective that they may need to spend a day or two in the newborn ICU, or they may require additional supplement of oxygen, and that can interfere with initial bonding and time spent with the mother. Other things that are important right at that final maturation stage are things of temperature development for the newborn, as well as control of their glucose levels. So we don't like to intervene on the behalf of the baby for early delivery unless we feel there's really a strong indication to do so. And the newer data supporting that it's really not until the much higher bile acid levels and perhaps later in gestation that the risk is really increased, that we can now, as I said, take a more nuanced approach to each patient and tailor a delivery plan that is beneficial for both her and her unborn child.
That's great. Thank you for that. And Professor Williamson, do you see any difference in the UK with trying to get patients to a term gestation of 39, 40 weeks? Is that different in the UK, or is this something that you're trying to do now in the UK?
In the UK, increasingly, people are considering maternal bile acid concentrations in their decision making. And I certainly, when I speak to people, would encourage obstetricians or obstetric physicians who are to continue to monitor bile acids from 36 weeks. But if they don't go above 40, there is really no evidence that there is an increased risk of adverse outcomes. And even from 40 to 99, providing they're checked regularly, there is no increased risk of stillbirth. Now, of course, we have to individualize care. Some women will have very high liver transaminases, and you could be worried about that. Or other women may find the pruritus, the itch associated with ICP, very, very distressing. And there are some women who sadly have had bad outcomes in the past where we would individualize decisions. But if we can, we try to prolong gestation, certainly till 39 weeks, if we don't have results from bile acid measurement that make us very worried. And I would say I would consider delivery from 35 to 36 weeks if the bile acids were above 100.
Thank you. So turning our attention to the patients, and I'm referring to both the mother and the unborn child, what is the impact to the mother with regards to ICP and having ICP? When does it present? How does the patient know they have ICP? When do they typically present to their doctor? Professor Williamson, I'd love to hear some of your thoughts around that.
Typically is a good word. ICP does not present in the same way for all women. Typically it presents at about 34 weeks with itch. And typically women experience the itch either all over or on the palms or the soles. But women may have a different pattern of itch. Some women have very, very minimal itch. For other women, it can be very, very severe because the itch severity does not correlate well with the biochemical changes. Typically, however, women present at about 34 weeks with generalized itch when the caregivers will measure their blood tests and find raised serum bile acids and often raised liver transaminases as well. Having said that, some women present as early as 7 or 8 weeks of pregnancy, and other women can present later. For women, the itch severity will influence their experience of the disease. If the itch severity is high, it can cause lack of sleep and be very, very distressing. For women with the most severe itch, they can find it difficult to wear normal clothes. I have had women who can only wear satin clothing back to front so they can't feel the hems of it and the stitching on the clothing. So for those women, the itch and the sleep deprivation is a major problem. I have managed women where the itch has been so severe. One woman gave herself frostbite from putting her feet into a bucket of iced water. And I have known women who have been suicidal with the itch. Having said that, not all women have such severe itch, and women can have significant ICP without severe itch. And many women are aware of the potential poor pregnancy outcomes associated with high bile acids or severe disease. And of course, that is a worry to women. Something I often say to women, they will often say, have I caused this in some way? It's very, very important for any woman listening to this to know that she has not caused ICP to occur to her pregnancy. Most women are predisposed and therefore they develop it. So the experience is variable, but it can be very distressing. I would also say the patient organizations internationally are very, very valuable for reassuring women as well.
Thank you very much. Dr. Kohari, any additional insights from a US perspective in how life is impacted for those patients with ICP?
I think for most women with ICP, in some ways, it's sort of torture. The itch that they have can be, as Professor Williamson alluded to, really disruptive to their daily lives. They can't get comfortable. They can't sleep at night. They're very distracted from their other tasks, whether it be working or caring for their family. And it's very challenging. And it's highly variable. Some women have hardly any itching at all, and some women, as I said, can't sit still. They're literally scratching their skin off. And we don't have a great solution for the itching either. And that's what's additionally frustrating for both providers and for the patients. Not great options for relief of their symptoms. Some things seem to work for some patients, while the same thing does not work for others. So it is a very disruptive diagnosis for many women that face this disease.
So just giving our listeners and our viewers of the webinar an insight, we've talked a little bit about the impact to the mother. Dr. Kohari, what's actually happening in the unborn child at this stage with a diagnosis of ICP? Why are there risks of stillbirth or early delivery as a therapeutic? Why are we concerned about that? What's actually happening with the unborn child?
So when there are elevated bile acids in the maternal bloodstream, the bile acids are preferentially shunted into what we call the fetal compartment, meaning they are transported from the maternal side to the fetal side, because the fetus, although creating their own bile acids, has less. So the high volume goes to where there's low volume. And we know that bile acids are toxic or irritating, and it affects the way that cells function. So one of the leading theories as to why there's an increased risk of stillbirth, for example, is that the elevated bile acids circulating in the fetus or the baby, it actually causes the cells of the heart to start firing for the heartbeat in an abnormal way, and leading to what we would call arrhythmias, or prolongation of the heartbeat. And over time, that could, potentially lead to an arrhythmia that is not, something the baby can recover from, and ultimately leading to stillbirth. So that's sort of one thought as to why there is increased risk of stillbirth. As I also mentioned, bile acids themselves are irritating and somewhat toxic to the environment. So I think the theory of that chronic irritation, that chronic exposure, is one of the reasons why we think that there's an increased risk for preterm birth, as the presence of that substance is leading to rupture of the membranes, because it weakens the amniotic sac and then causing contractions to ensue. There's also an increased risk of something called meconium, which is actually a baby bowel movement, baby poop. And we know that bile acids affect the gastrointestinal system, or the intestines. And so we think that it's in some ways provoking the baby to have a bowel movement while still in the womb.
Switching gears again to focus on perhaps some of the listeners and viewers that may actually be healthcare providers here, doctors and midwives. How does a patient present to you? You've managed many patients, both of you, in your careers. How do you treat these patients? What are you looking for in terms of their diagnosis, their symptomology, and what recommendations for treatment can you offer to these patients?
Well, most importantly, as most healthcare professionals, will take a good history, listen to the women to hear what their presenting symptoms are. A proportion of women will have a family history. Some may have had abnormal liver tests, having taken the oral contraceptive pill in the past, or antibiotics. So there may be a tendency to cholestasis either in the woman or in her family, or a tendency to gallstones or some disorder of the liver or gallbladder. I also then ask about the severity of the itch, very importantly, whether it stops women from sleeping, because this is something that influences their quality of life. Whether, if they have had the condition before, they've responded to any treatments. I do also always ask about the colour of their urine and their poop. This is because a proportion of women tend to have fatty stools, and when they try to flush the toilet, they may not be able to flush them away. And this is a subgroup that will have very little bile acid in their bowel and are likely to not absorb some vitamins, such as fat-soluble vitamins and vitamin K so well. And that's important because they could be more at risk of problems with bleeding, either at the time of birth or for the baby. Those are the principal things I would ask, and then I will talk through treatment options with them. And again, as I said earlier, I do think about mother disease and pregnancy disease because the considerations are slightly different. For the mother, we consider possible treatments to help with itch. Unfortunately, we really don't have a good medicine for itch at the moment. Some women find that aqueous cream with some menthol in it just cools their skin, often before they go to bed. I find some women may have a cool shower or a cool bath and put it on, and it may enable them to go to sleep, but it doesn't treat the disease. It just helps a little bit with some of the symptoms. There was a large trial performed in the UK a couple of years ago, the Pictures trial, which sadly did not show that the most commonly used drug, ursodeoxycholic acid, is very effective at treating itch. There's likely a subgroup of women who do improve, and the small effect urso has may help some women go to sleep. but it doesn't really treat the itch in the majority of women. And there's another drug, rifampicin, that is used outside pregnancy that can help with itch, but there's very limited expertise in pregnancy. Some people give antihistamines. There's one, Piriton, that can be bought over the counter. But I do tell women this does not treat the disease. My view is it makes some women a little drowsy, but that's the only way really I think it helps them. So those are the main things I talk to women about, as well as vitamin K, as I've mentioned. In terms of pregnancy outcome, again, we have very limited data. We published an abstract earlier this year that suggests that the drug ursodeoxycholic acid may be of some help for preterm birth, but we don't have a good enough medicine at present. So I do explain this to women, and that we need to check their bile acids very regularly, because this is the test that helps us stratify them and identify the group whose bile acids are going up. Would you like me to expand any further?
Well, I was going to ask one question which we haven't asked so far. You see a lot of these patients because they're referred from other hospitals. What would a typical obstetrician in the United Kingdom, how many patients a year would an obstetrician see that has ICP or makes a diagnosis of ICP? Is it common or rare?
It's relatively common. It affects about 1 in 150 pregnancies. So a typical unit would see more than 30 cases a year.
That's great. And Dr. Kohari, your experience of presentation of patients' treatment in the United States, does that differ at all from what Professor Williamson just described?
I think in the United States, the general concepts are very similar to what is practiced in the UK. Presentation for most women is initially with itch, and the astute clinician getting more information about the itch. It's not uncommon for women, especially in the late second trimester, early third trimester, to have itching on their skin just due to the growing abdomen and the presence of maybe developing stretch marks and things like that. So if a woman's complaining of itching, it's really important for all providers to ask more questions, not just say, put some lotion on it, it'll be fine, because that itching could be a warning sign of cholestasis at pregnancy, as we've spoken about. The other time I often see patients with cholestasis is when they're getting worked up for something called preeclampsia. And that's when women can have high blood pressure, protein in the urine, and sometimes abnormal liver function tests. And in the workup for that, the liver function tests are abnormal, and people forget to ask questions about itching. And it turns out if you start asking questions about itching with women with abnormal liver tests who maybe their blood pressures aren't so high or aren't as concerning for preeclampsia, they often have cholestasis at pregnancy. So again, it's sort of thinking about it from a couple different angles, both the itch, but also if you are seeing the liver abnormalities in the blood work, could cholestasis actually be the underlying culprit? And then as far as initial management, I think for the average provider in the United States, it's very customary to prescribe the ursodeoxycholic acid that Professor Williamson was speaking about earlier. And although the data is very mixed on the efficacy of that medication, the environment in the United States is slightly different, and people are much more apt to start some form of treatment, however ineffective it may be. Other management strategies include giving things like diphenhydramine or Benadryl, again, mainly to induce drowsiness to help with sleep, as well as some topical lotions to try to help with the symptoms. But we don't have a treatment for the disease itself. All we have are things that may put like a small Band-Aid on the symptoms, but not really treating the issue, both from a fetal side and a maternal side.
That's great. Thank you. Professor Williamson mentioned that wasn't a great deal of research and not many therapeutics for what sounds like a very challenging disease. Dr. Kohari, Any reason why we're not seeing the amount of research that perhaps you both would like to see? And then I'll ask the same question to Professor Williamson.
Well, I think it's multifaceted. First and foremost, as has recently come to light with the COVID pandemic, pregnant women are generally excluded from the study of most new medications and therapies. So we don't have a lot of information about how to treat cholestatic diseases for women who are pregnant, let alone then also with this pregnancy-specific disease of cholestasis of pregnancy. And then there's varying degrees of prevalence of this condition. So in some places, depending on the ethnic population, the prevalence is actually quite high as 5% of pregnant women. While in other parts of the United States, which is a very diverse place, you may hardly ever see cholestasis of pregnancy. So because it's not as common as some of the other pregnancy-related complications, I think it just hasn't gotten quite the same spotlight that it deserves as compared to some of the other conditions that we commonly see in pregnancy.
Thank you. And Professor Williams, I know how passionate you are about research in pregnancy. Tell me what your thoughts are around how can we grow the research space for pregnant patients?
Yes, I absolutely agree with what Katherine said. Sadly, pregnant women and children have been excluded from clinical research for a long time because of often unfounded fears. And it means that pregnant women haven't been able to benefit from good science and good research being performed to improve their outcomes. For many conditions, not just cholestasis, women are using drugs that have been used for 30 to 50 years because of fears about giving any drug to a pregnant woman. And I think now people are realizing that we have to be more intelligent about our clinical trials in pregnancy and in children. So I am delighted that the landscape is changing, which is wonderful. Resources are important. It's always difficult to obtain resources to perform research, and good research is not cheap, so requires more sizable resources. And I think as we understand cholestasis more, it will be easier to obtain research funding because now we know how to stratify women. I think in the past, there was a perception that maybe the adverse outcomes weren't so common amongst the population who don't see the cases so often, because if they were diagnosing cholestasis in a woman with serum bile acids that might be 15, and possibly she's a woman who'd just eaten a bit of a fatty meal and didn't really have abnormal tests, of course they wouldn't see an adverse outcome in that woman. But now people understand the risk groups better, and they do understand that there is a subgroup that we need to understand better and find ways to prevent their risk of the adverse outcomes.
That is a wonderful answer. In the practical sense, Professor Williamson, how do you encourage a patient to participate in clinical research?
I think the most important thing is to be honest and straightforward with women, and to assure them from the beginning that it is absolutely fine if they don't want to take part in research. However, it is also possible to explain what we understand about the disease. And for ICP, the thing we understand is that a rise in bile acids puts the pregnancy at risk. And at present, we don't have a reliable way to bring the bile acids down. So what I would do is explain to a woman what we're concerned about and the reasons why we think a particular study could be of benefit. But I would always be very honest with the woman that she would have a chance of being on a placebo and what the actions would be should that be the case. And for a trial where we don't know the outcomes, I would explain why we think a drug could be of benefit. But of course, if we absolutely knew, we wouldn't be doing a trial. So I think it's important to talk through the rationale with women. And of course, talk through the potential risk for the mother, for the baby, but also the potential benefits. Because there are benefits, otherwise we would not be in equipoise, potential benefits as well. And also philosophically, the importance that not only possibly a trial they take part in would tell us more about them and their responses and outcomes, but it would also help other people in the future. And I think often women coming to research hospitals, such as the hospitals where we both work, are aware that we have, I hope, what would be considered very progressive services and services that we're proud to work in, partly because we're research hospitals, and therefore we know about the cutting edge discoveries and we aim to deliver them to all pregnant women.
Wow, thank you. So we're getting close to the end of our webinar here today. This has been a wonderful exchange. I've learned so much and enjoyed hearing so much from both of you, and how much expertise and dedication you place into managing patients with ICP. As we close out, what are the key messages for managing ICP? Maybe I can go to Dr. Kohari first, then come back to Professor Williamson. What would the message be for the referring physicians that may be watching this webinar today?
Well, I think one of the key messages is don't discount patients. If they have a complaint, it's a recurrent complaint, especially one as seemingly as mundane as itch, take it seriously and ask the patient more questions about what exactly is going on. Send bile acids. They don't have to be fasting, but certainly send them. And in the United States, currently, it's not recommended to check serial bile acids, but I'm actually a firm believer that we should be checking serial bile acids. So even if a initial blood test comes back as normal range, but if the patient's symptoms persist, check again. The symptoms may onset several weeks before the bile acids may become elevated. So it's worth rechecking and checking again. And then monitoring your patients closely and delivering, based on a risk stratified approach, deciding what's the best time for mom and baby based on the peak bile acid level.
Thank you. Professor Williamson, what's your message to obstetricians who are seeing potentially these patients with ICP?
I agree with everything Katherine has said. I would also encourage them to think about stratifying women in terms of itch. So I absolutely agree they should repeat the bile acid measurement because they can go up subsequent to a normal test, but also establish whether a woman has eaten or not when they're taken. And I would discourage obstetricians from starting treatment, particularly with ursodeoxycholic acid, until they know they have a diagnosis, and to consider, is it the right thing to do? It may be, but it may not. So to individualize care for women and to always feel happy to pick up the phone. I'm sure Katherine would agree, if people aren't sure what to do, we're happy to talk to them.
That's great. Thank you to you both for your time today and sharing your experiences, your expertise, and your leadership in this space of high unmet medical need. It is evident to me there is still a lot we can do in this space for pregnant patients with ICP. So on behalf of the viewers and the listeners, thank you, and we'll continue our endeavors in research. Thanks very much. We'll close the meeting.